Starting the Kfog Edge webinar, the fifth episode of this current series. This is being organized by the Oncology Committee of Kfog in association with the Angamali, Kochi, Palakkad, Malanad, and Thrissur ONG societies. And it has been a series of webinars which we have been planned right from the beginning of this year of Kfog. And we have planned for 23 webinars. And of this, we have already completed 4 with an very success and very huge participation from the members across the societies inside Kerala and outside Kerala. And now we are starting with the webinar, and once Dr. Mumtaz joins, she will have the introduction about this webinar. Meanwhile, I request Dr. Sujitra ma'am to welcome the gathering. Over to Dr. Sujitra. Madam is the coordinator of this entire EDGE webinar series. Madam, please. Sujitra ma'am, for you.
In the meanwhile, Dr. Nayak has joined, sir, but he's in the attendee list. Can we please upgrade him to the faculty, sir? Dr. Nayak, the president of the Malanadu Society, sir.
Yeah. I'll just send a message, so they'll be upgrading him in a few minutes. Meanwhile, I consider this as an honor to welcome all the faculty members. The Dr. Anantha Narayanan, who will be speaking on the screening of cancer cervix, and Dr. Binoda from CMC Vellore, and Dr. Anantha Narayanan, he's from GKNM Coimbatore, and Dr. Binoda from CMC Vellore, who will be speaking on HPV vaccine. And we have Dr. Shruti Shivadas from Kidwai Cancer Hospital, Bangalore, who will be speaking on update on management of carcinoma cervix. And we have Dr. Aisha from Rajagiri Hospital, Alua, and she'll be speaking on role of radiotherapy in cancer cervix. And we have Dr. Preetha George from MOSC Medical College, and she'll be speaking on the national policy on CA cervix and the current scenario. And all the chairpersons for all the sessions, the Dr. Ambuja, Dr. Letika, Dr. Nayak, Dr. Anjali, Dr. Kamappa, Dr. Srija, Dr. Nishi, Dr. Anuj, Dr. Joji, and Dr. Mini from all the participating societies, and all the presidents and secretaries of this society, and my dear Kfog Secretary General, Dr. Supash, the coordinator of this EDGE program, Dr. Sujitra, and the organizing committee convener of today's program, that is Oncology Committee Chairperson, Dr. Mumtaz. I all heartily welcome you to this today's webinar on behalf of the Kfog and the entire organizing committee. I welcome all the delegates who are attending this program. With this a few words, I declare that this webinar is inaugurated and request Dr. Sushma V. Dev. We have a guest of honor from our neighboring state of Karnataka to say a few words as guest of honor. Before that, Neha has shared her CV. Neha, please read the CV. Neha, please. Neha is there?
Yes, sir. And yes.
Please read the CV now.
Yes. I would like to invite Dr. Sushma V. Dev, the guest of honor. She is an associate professor and unit head, Mysore Medical College. A director and chief consultant, Aishwarya Hospital, Mysore. I would request her to speak a few words.
Thank you so much for the kind introduction. Very good evening, everyone. It's my immense pleasure and honor to be part of this exuberant and scientific session of Kfog EDGE series. And I personally thank Dr. Konjumaidin sir for inviting me to this forum. And of course, the Kerala and Kfog team known for the excellence in all the scientific CMEs and webinars. I wish them all the great success in their upcoming webinar series. With the permission of the President Kfog Koimuddin sir, I take this privilege to invite all the Kfog members, faculty members to your Foxy, which is going to be held in Mysore. Can I share my screen, please, at this point?
Yeah, Neha, stop your sharing. Yeah, you can share. Dr. Sushma, you can share.
Yes, sir. And today, very special day, Mother's Day. And I wish all the gorgeous and stunning mothers the happy Mother's Day to everyone. And it's a special day for me to be introduced to Kfog on this special day of Mother's Day. And it's a great feeling to be with you all.
Kfog for the introduction of the webinar. Ma'am, please.
Good evening, our respected President, Dr. Kunjumoideen, Secretary, Dr. Subhash Malya, and all senior members here, our chief guest, Dr. Sushma, all the faculty, and more than 100 delegates have already joined. So it's a pleasure to invite all of you for the first webinar by the Oncology Committee under the Kerala Federation of OG Society. Hoping this will be a real great academic treat for all of us, because we have extremely good faculties from South India to talk to us about update in cancer cervix. So without wasting much time, let's move on. Over to you, Neha.
Now for the felicitation, I would like to invite the president of Angamali OG Society, Dr. Jinsi Kurian. Ma'am.
Neha, please. Dr. Sujitra has joined back. Madam has disappeared in between from the beginning. Dr. Sujitra, ma'am, say a few words.
Good evening to you all. It's really a pleasure to be here because this is the 5th Kfog webinar, the Kfog Edge. And every time the edges are sharpened and our our knowledge gets more and more updated with these webinars. And I'm so happy that our president, Dr. Kunjumoideen, is really taking this up. It's really increasing the awareness and knowledge of all the members, and especially cancer cervix. We know that WHO has called for elimination of cervix by 2030. And so we know it is a preventable disease. There is vaccination, and we know the cause of the disease, and it is totally curable. So this is one cancer that we can really take up and go ahead and try to eliminate it from all the women. And in Mother's Day, the best that we can give to women of our society is elimination from this disease through 90% vaccination of children, 70% screening, and 90% of treatment of this disease. So as WHO says, it's 90, 70, 90, and definitely we will definitely put in our efforts to eliminate this disease. And this webinar is really something wonderful, because I have seen there are speakers from all over South India and all experts also. So thank you.
Thank you so much, ma'am. Now, for the felicitation, I would like to invite the president of Angamali OG Society, Dr. Jinsi Kurian. Ma'am, could you please speak a few words?
Many of the presidents are not here. You can see, invite whoever is here. Dr. Naik is there. Dr. Naik. I see he has joined. Then we will quickly move on to the vote of thanks. Dr. Subhash, please.
I would like to invite Dr. Subhash Malya, Secretary Kfog, for the vote of thanks.
Respected President, Dr. Kunjumoideen sir, President-elect Dr. Suchitra Madam, and our senior fraternities, and the Chairperson of the Oncology Committee, Dr. Mumtaz, and all my respected presidents and secretaries from all over the state, senior members of the fraternity, sir, thank you, sir. Thank you very much for joining us. I would like to thank all the faculties who have joined us, as resource persons today. And also I would like to thank all the panelists and also the MOC, the in-charge, Dr. Adarsh, and the whole team for this wonderful thing. And I would like to thank the sponsors also of this whole event, the Astria Life Sciences, for their support on this. Thank you very much.
I would like to invite Dr. Adarsh, Associate Professor and Division Head, Gynec-Oncology, Malabar Cancer Center. He is currently working in Malabar Cancer Center. He has done his MBBS from Government Medical College, Kochi, and post-graduation from Government Medical College, Trivandrum. He has got various research publications in his name. Sir, I would like you to speak a few words.
Thank you. Thank you, Kfog, for this great opportunity. And I am myself Dr. Adarsh, Associate Professor and Division Head of Gynec-Oncology, Malabar Cancer Center. And I think we will move on to our sessions. Our first session is Screening of Cancer Cervix, What is New? By Dr. Anantha Narayanan from GKNM Coimbatore, Hospital Coimbatore. I welcome Dr. Anantha Narayanan for a great session. Welcome you, sir. Please, over to you, sir. So, chairpersons for this session, Dr. Ambuja Mohan, she is a senior consultant, Gyno IVF Hospital, Angamali, and Dr. Latika Sukumaran, and is a consultant obstetrician and gynecologist, Geethajali Hospital, Ernakulam, Kerala. Okay. Let us move on to the session.
Is my presentation visible? Good evening, everyone.
Yes, sir. We can see.
Yeah.
You can
Okay.
put in slideshow.
Yeah, sure. Thank you. So thank you for the kind introduction. Sorry, my mic was mute. And good evening, everyone. And thanks for the opportunity. So the next 20-25 minutes, what we will be seeing is what is new in screening of cervical cancer. So I'm Dr. Anand Narayanan. I'm basically a radiation oncologist by training. I work at GKNM Hospital, Coimbatore. So I don't have any conflicts, but I have to acknowledge the work of our community oncology team. So this is our whole team. They work for the screening for cervical, breast, and oral cancers in the community for our hospital. So moving on to the presentation. So just a brief introduction on cervical cancer. Is the fourth most common cancer. I think most of us will know it. Second most common cancer in women. And in India, and still the most common cancer in most of the rural registries in India. So it's a big public health problem, no doubt about it. And almost all of these cancers are caused by human papilloma virus. And the IARC classifies at least 14 types of human papilloma viruses as an etiological factor for cervical cancer. And 16 and 18 types are considered as high risk, accounting for the high risk viruses, accounting for almost 2/3 of all cervical cancer. And 85% of the cervical cancers in the world occurs in low and low middle income countries. So this is very important because this is the countries where, the opportunities for screening and vaccination and prevention are not available. So this already has been spoken, and I think every one of us is going to use this slide 90, 70, 90. So WHO, World Health Organization, has got a vision for a world without cervical cancer, where all the countries have to reach around less than 4 cases per 100,000 women years by 2030. And how are we going to achieve it? By 3 strategies. One is vaccinate around 90% of girls with the less than, at the less than 15 years of age. Screen around 70% of women at least 2 times in their lifetime, and 90% of the women who have identified to have some disease after screening should receive appropriate treatment. So in my lecture, I think we already have the first point and the last point lined up subsequently. So what we are going to see is how do we do this 70%, right? So how do we say, what is a screening program? We all know screening is testing an asymptomatic person. And the screening programs can be categorized into 2. One is an organized population-based screening program, or is an opportunistic screening program. Organized population-based screening program is where it is done to all the people in the country. All of them are invited and all of them are given an opportunity. Whereas opportunistic screening is what happens currently in India, where a person who wants to get screened comes seeking for a screening test, and we screen them and report them, right? So that's what happens in India in pockets, either in the hospital or in a small set of community in different part of India. But whatever it is, this is the flow of what the screening. First, we invite and give them information, health information. They undergo screening, and the results are got. And if the screening tests positive, then we either go for a confirmatory test or we manage them. So manage the women with a positive test, and then if the treatment, if the cancer is confirmed, then we can treat the cancer or the precancerous lesion. So this is essentially what happens in a screening. And this is a mathematical model which has shown that if you see, we have got an effective vaccination available for cervical cancer. Still, screening has a very important role. Vaccination, I think the next talk is on vaccination. But what this model has seen is if we vaccinate the women, only vaccinate women. So what happens is by 2080, we can achieve our goal. But what happens is if we continue, there is a raised hand. I think I can take, if there is questions, I can take it later. Or do you want me to answer the question, sir?
You can answer later, doctor.
Yeah, okay,
after
fine.
the question.
Fine. So what model says is if we vaccinate and we do continue screening along with that, what we can do is we can blunt that shoulder. So the area under the curve reduces, and the number of women who are going to have cervical cancer till the vaccination takes adequate hold is much, much lesser if we continue to screen them. So that's where the importance of screening is there, even after we instate vaccination. So why cervical cancer is the ideal cancer to screen, I would say, because the other cancers, whether it's breast cancer or oral cancer, what we are trying to find is an early diagnosis, whereas cervical cancer is one place where we have a real potential to prevent this cancer. So that's why, because you can see that red box, there is a natural history of cervical cancer where the HPV infection occurs and most of them resolve on its own. A fraction of it will persist or progress to precancer lesion, and a fraction of that will manifest as an invasive cancer. And we have, for the natural history to happen, this takes around 10 to 15 years in women. So we have these 10 to 15 years of lead time to screen or to, prevent it. So we have a different screening strategies. Yeah. So right from detecting the HPV infection to detecting a microscopic changes in the mucosal, these mucosa, to a macroscopic changes in the mucosa. So we will be seeing one by one later. I'm not able to go to the next slide. Yeah. So what are the screening options available to us? The traditional screening option was either a visual inspection with acetic acid or leukocidin, or a cytology. This is what we have been using. HPV testing is a new, addition to this armamentarium. But you can see that there are a lot of screening that is being tested, including a molecular screening with protein biomarkers or mRNA biomarkers, DNA methylation biomarkers, or even we have a lot of artificial intelligence to detect all these visual pictures that is being used now. It is being tested now. So we will see one by one what is the approved ones are a visual inspection, cytology, or HPV testing. Coming to the visual inspection, we have to know about it because it's simple, affordable, safe. It's very easy to learn and practice. And even if we can train the nurses and other healthcare workers to do this, it's very rapid. We can get a real-time result, and it has a low cost in implementing, low cost of infrastructure and sustenance. Right. So what we have seen is the beauty is we have 3 big Indian studies that have done on this, whether this visual inspection can reduce the cervical cancer or the mortality. One in the rural part of Maharashtra, one in Mumbai, and one in Tamil Nadu in Dindigul district. So all of them have shown a reduction in the incidence of cervical cancer as well as a reduction in mortality. I will not go into the details. But what is the problem with the VIA? Because it's just a visual inspection, it is dependent on the person who is inspecting. And it is very difficult to standardize the training and quality assurance, and the sensitivity greatly varies between who does the test, which healthcare worker is doing it, what is the supervision, and what is the quality assurance that we have. And the sensitivity is very, it's poor. So which will result in a lot of cases coming for the subsequent test. Coming to pap smear, it has a better sensitivity, but the problem is we are reliant on a pathologist. So we need a pathology infrastructure and pathology personal training. We need to have adequate pathologists to do this. And we cannot do a bulk screening in a day, because a pathologist can only do so much of slides a day. So, and also it requires a robust quality assurance and standardization. And there might be a delay in reporting because it has to go to a pathologist, then the report comes and we have to recall the people, and there can be an attrition at that point of time. So it is possible, because still a lot of hospitals are doing it. If the patient is coming to the institution, it's still possible to do a pap smear in an opportunistic or an institutional setting, but it's very difficult to implement in an organized population setting. And I'm sure we all know that it has been tried and we couldn't do it in India. And what are the issues with this traditional screening method? It suffers from a low sensitivity as in visual inspection. You don't have adequate infrastructure as in cytology. And, there's a frequency of screening because every 3 years we have to screen. And usually these are all picks up in a late stage of natural history. So either a microscopic phenotype changes has to occur, or a macroscopic changes has to occur to pick it up. So can we pick it up a little earlier when we know that HPV is the cause of this, and can we pick it up a HPV stage? That's what is being done in all high resource setting. So the standard of care is an HPV DNA test, where it has a very good sensitivity of around 95% and specificity of around 90%. It is objective test because it is usually an automated testing. Because it is automated, it's reproducible and robust. It has a built-in quality control. We can do bulk testing. So how much of our samples we collect, we can do bulk testing, and we can get the results in a couple of days. But it requires a good quality control. And as of now, it is quite expensive for a population-based testing, but the cost is coming down. So comparison, compared to VIA villi, HPV testing is definitely better. Compared to cytology also, it's better. So what has happened in the last recommendation from World Health Organization is, WHO, even though usually they give recommendations for all the countries, right? Unless the US task force or American Cancer Society, they usually consider all the developing countries into account. But still they have moved on to HPV testing, and this time they have made HPV DNA detection as the standard test to screen cervical cancer. So this testing has to start at the age of 30 years, and we have to do it every 5 to 10 years of age. We go to the right panel, they allow the sample to be taken either by the healthcare provider or the self-sampling. That we will come to that later. We can stop screening at 50 years if the 2 consecutive samples at 30 and 40 years of age are negative. If you are starting the program, then we try to achieve 2 lifetime screening, one at 30 years and one at 40 years. If HPV testing is not available, they recommend that the cytology and visual screening, which used to be the standard recommendation, now it has taken backseat. Only if HPV testing is not available, that continues to be done every 3 years. And if at all your screening test with PAP or visual inspection comes positive, then they recommend that the next test has to be an HPV testing. So it's coming up in a big way. The HPV testing is the standard now. But in spite of having all these tests, what is the problem? See, there is a subjective patient experience, right? There is a feeling of embarrassment and shame. A lot of women are not ready to undergo this testing because a lot of socio-cultural groups, there is a reluctance to have a physician see and touch their genital area. There is an experience of discomfort and pain. And there is a lack of importance of HPV testing and cervical screening, which maybe as low as 16% of women are aware of, importance of screening. So we provide VIA villi for free. Almost all of the government, even Tamil Nadu government provides it for free. But still not all women respond to these invitations. The screening acceptance is very, very low. in our work, in our community, screening, we showed that the acceptance to screening is as low as 30%. So we go to a panchayat, we invite all the women, less than 30% of them come to the screening camps. Okay. So the screening participation is low, especially among certain socioeconomic groups and low income groups. So that has to be taken care of account, because the low income group is the one who actually have the higher incidence of cervical cancer. So what is the new thing in the block? That is a self-sampling. I have to talk about self-sampling because this is nothing but the person self-samples their own cervical mucosa. So this is have a cap. That's the same HPV testing kit. The only thing is they have to insert their the brush into their vagina, and till it touches they experience a resistance, and then they brush it, and the brush is taken out, the stylus is broken and put it into a solution, capped and sent for testing. Okay. But what is the problem that, intuitively we can think that, okay, it's not a healthcare worker. We are not visualizing it. It's a self-sampling. It can suffer from a low yield and a lot of false negatives, right? So what we did was, there was a pilot study that we did using an HPV testing, around 200 people with self-sampling and 200 people with healthcare collected HPV testing. Those who refused HPV, those who are reluctant to come for healthcare worker directed testing, they were offered a self-sampling. So there was a questionnaire, validated questionnaire, that was given to these 209 women who underwent self-sampling. Almost all of them found it easy to use. All of them, thought that this is more comfortable and they would recommend to others, and all of them preferred self-sampling over a physician-collected sampling. The experience of pain and discomfort was experienced by around 10% of people. So what about the adequacy of sample? So this is what we got. So there was an HPV positivity rate of around 8% in a healthcare collected sample, and in around 10% in self-sample, collected HPV testing. But what was glaring was the colposcopy rate. So those who are positive, almost 90% of them turned out for colposcopy, whereas only 50% of them turned out for colposcopy. Maybe again, there's a hesitancy about somebody else taking a sample for colposcopy. We don't know, in spite of our colposcopy expert being a lady. But that's something that has to be addressed. So coverage rates, there was a drastic increase in the coverage rates from about 30-40% to around 65% who are willing to attend the camp when they were offered self-sampling. So all the women who did a self-sampling found it convenient, painless, and preferable. So majority of the women agreed that self-sampling would be the preferred way. And, our study showed that the yield is almost equal to the healthcare worker collected sample. So we have initiated this cluster randomized study. Our aim is to screen around 4,000 women, where a control arm would be to health educate them and offer them a healthcare worker collected HPV testing. So both of the arms have HPV testing. And those who are reluctant to go for healthcare worker HPV testing, they will be offered a self-sampling as well. So the recruitment is over. We are analyzing our data. So this is about self-sampling, and there are a lot of new things coming up. There are they also say that there will be shedding of HPV DNA in the urine. So urine sampling is also being considered. Artificial intelligence is coming up in a big way, where digital imaging using your mobile phone, because interpretation of colposcopy, again, we have to train a lot of people in interpreting colposcopy and visual inspections. So rather we use a mobile phone or any camera to take a picture, high resolution picture, and that will be sent to a central a place where these things will be interpreted either using an AI or using a person. So this is future. Future seems exciting. So there are a lot of options available for screening. So that's it from me. I'm happy to take any questions. Check.
Hello.
Yes, ma'am.
Thank you very much, Dr. Anand Narayan, for your
It's a pleasure, ma'am. It's a pleasure to address.
Informations all informations we got. Actually, compared to the PAP test and VAA, HPV testing is definitely good to predict the incidence of to detect the cancer. Actually, in India, after HPV testing, there was a 53% reduction in the incidence of invasive cervical cancer, and there was a 48% decrease in incidence of mortality due to CA cervix. And in European study, there is a around 70% decrease in the incidence of invasive cervical carcinoma. But the thing is that the population has to get more awareness regarding the disease. Then only we can reach our target of 2030. This decrease in the cervical cancer. So we have to inform not only the medical professionals, the other societies and groups, and give them the leaflets regarding the cervical cancer, and to distribute among the other population, so they can be more aware of the disease and they will come for screening.
Correct.
And this lower resource income group, this WHO recommend, of course, the HPV testing for around every 7 to 10 years. So that also decrease the incidence of cervical cancer. But the thing is that in Kerala, even though highly educated people in the low resource group, the awareness and the availability of the screening method and the treatment is very low. That is the problem in detecting the cervical cancer. Even if the patients come to our clinic, they are very reluctant to take the sample, because they will tell, next visit we will come, and they won't come at all. And maybe due to financial problem, but nowadays insurance companies have put forward, and so many people are willing to screen with the PAP testing. And the VAA also, among the postmenopausal women, it's very difficult. Sometimes it is very difficult to get the proper, which is the, this is the problem among the postmenopausal women. So what is your suggestion among postmenopausal women to get this one?
Yeah. So the two traditional reasons why we were reluctant, why the healthcare professionals were reluctant, was one is the cost.
Yeah.
So if we see it requires only 2 times a lifetime, if we can do it 2 times a lifetime, it's enough. So and the cost can be negotiated. So we all know how it's a market force. So we are negotiating in a bulk. The cost can be reduced. The cost is no longer a problem. I mean, that can be done. That can always be negotiated. The second thing that we were worried about was, what if we find people? Do we have adequate people to treat them? So at least I don't think Kerala should have that problem. I'm a radiation oncologist. I know that every district hospital has a radiation machine. Even if you find an invasive cancer in an advanced stage, it really doesn't matter. You have all the facilities to treat. Regarding postmenopausal, ma'am, definitely VAA will because there will be an involution of this transformation zone inside in postmenopausal women. The VAA will sensitivity reduces considerably in postmenopausal women. So definitely HPV will be a good thing. But again, the screening, WHO again recommends that if you have a problem with infrastructure, concentrate on the younger women. Concentrate on 30 to 50s, finish off within 30, because we need at least one, we need only once in a 10 year, right? 10 years. So if we start at 30 and 40, we can do both the things when they are premenopausal. So yield or a transformation zone, I mean, I don't know about how will be the HPV. I don't think the involution of transformation zone should be a problem for HPV collection. But even it should not be a problem, because we will finish our screening within that period.
Yeah, for postmenopausal women, HPV testing is more good than...
Definitely.
And another thing regarding the vaccination, the cost is a problem, no? nowadays the government has to use the free vaccination. Then only the people can accept. Otherwise, the financial liability is very preventing them to take vaccination. Even in school also, they have to be free. The vaccination must be free. So we all people must try to make alert for the government to make this vaccination free. Then only we can achieve the target.
I will leave this question to the next speaker because I think the next topic is on vaccination.
Yeah.
So,
very much, Dr. Anand Narayan, for your
thank
love
you.
and more information. Thank you.
Thank you, ma'am. Thank you.
Dr. Latika, ma'am.
Hello. Hello. Namaste. Happy Mother's Day to all who have joined. I'm delighted to be part of this webinar and thank you, Kfog Oncology Committee, for giving me this opportunity. It was an excellent and informative talk. I want to add to this that the WHO has suggested certain put forwarded by the WHO certain strategies because of the paucity of fund and lack of workforce in India. WHO suggested that there is single-time lifetime screening after 40 years and picking up the high-risk cases where because of more than 40 years age and high parity and women with gynecological symptoms. Because then the burden will be very low because we know that 90% of mild dysplasias resolve spontaneously or after treatment. So only 10% cases can be picked up and it will obviate the follow-up of mild dysplasia cases. Hence the burden of follow-up will be reduced. So this can be done by this application of tumor markers, which is of low cost, easy to apply and reliable. Comparing to the HPV DNA testing recommended by WHO, which is costlier and not taken up by Government of India. Next is to enhance the sensitivity and efficacy of cytological screening programs by increasing the trained workforce. We can include MSW students or workers and mobile screening clinics to increase the screening rate. What is your suggestions on this?
I'm sorry.
Hello, Dr. Anand.
Yeah, I'm hi.
Can you throw light on the tumor markers?
Ma'am, I don't know what tumor marker has been approved.
Ignore pleomorphic count, which increases with the dysplasia. If the count is increased, it has to
sorry,
be...
ma'am. I'm not aware of any tumor marker that has been approved as a detection as a screening for cervical cancer. So still the standard of care or standard of screening is either standard of screening is HPV testing. If it is available and if it is not available, it's either a cytology or a visual inspection.
I think HPV oncoprotein E6 and E7 there. That's the thing. What do you say, sir?
Ma'am, I am not aware of. Is it in the blood or?
No, it's DNA, mRNA, and
No. Is it in the blood? The sampling is blood or the cervical mucosa?
Anyway, there is no invitation from any side. Okay, none of the organization recommends these markers.
Yeah, no, there is no.
Okay, then I want to add a few points on this session. Actually, one of the major concerns is there is now what is happening through disparity when the screening should start. Actually, in developed countries, what happened, the prevalence of vaccination increased. So what they did, actually, they increased the age cutoff for starting the screening. So if you look at American Cancer Society, they increased their age of starting screening to 25. But most of the other organizations like ACOG, SGO, and ASCCP still holds that they recommend that screening should be started at the age of 20. What WHO says actually we should start at the age of 30 years, and they also recommend that we have to follow high performance tests and minimize the pap smear testing, and an average of 3 high performance tests in a lifespan. What they recommend. And another thing is the gap between the HPV DNA testing. I think Dr. Anandaran already mentioned 5 to 10 years. So lot of randomized trials happened on this, whether we can increase the gap between HPV screening tests. And one of the study, HPV focal decade study. In this HPV focal decade study, they found that even if you increase the gap between, if initially if she is negative for HPV DNA testing, and if you increase the gap between one HPV testing to another to 10 years also, it won't affect the effectiveness of the HPV DNA testing. So,
sorry to interrupt, sir. We are running out of time. Can we move on to the next talk?
Yeah. So I am only telling few points. I want all these points I want to add. I added. Okay, now you can go to next session.
Yes. Thank you, sir. Thank you, ma'am. Moving on to the next talk, we have a talk on HPV vaccine, the latest guideline. The talk is Dr. C. Naik. He has done his MBBS and DGO and is a consultant OBG in St. Joseph's Hospital, Kodamangala. He is the president of Malnadu OG Society. I welcome you, sir.
Thanks for the introduction. Good evening, everybody. We have already heard about the screening of cervical cancer from Ananda Narayan sir. Next, we have how to prevent it. We know prevention is better than treatment. The only cancer in gynecology that can be prevented by vaccination is CS cervix, which is caused by HPV. So, by HPV vaccination, we can prevent up to 70% of the cervical cancers. And so many vaccines are available, that is the bivalent, quadrivalent, and nanovalent vaccines in the market. We will hear latest guidelines on HPV vaccination from Dr. Vinobha. Dr. Vinobha has a MCH degree in gynecology, apart from MBBS, DGO, and DNB. She is associate professor in Department of Oncology at CMC Vellore. We welcome to this webinar, madam. I invite Dr. Vinobha to share her knowledge on HPV vaccination and its guidelines. Over to you, madam.
We also have Dr. Anjali H. She is a consultant obstetrician and gynecologist in Vatiyayat Hospital. She is the secretary of Malnadu OG Society. I welcome you, ma'am. Moving on to Vinoda, ma'am. Ma'am, can you please?
I'd like to thank Kfog for this opportunity. And I would like to thank Dr. Ananda Narayan for setting the pace for my talk. I hope you can see my screen and you can hear me well. So I've been asked to address recent guidelines in HPV vaccine. I just brush on what we know so far. Cervical cancer and cervical pre-cancer is just the tip of the iceberg when we look at HPV-associated cancers. We have other cancers which are also associated with HPV. These include oropharyngeal cancer, anal cancer, vulval and vaginal cancer, and penile cancer. And compared to cervical cancer, where almost 90%, 99% of cervical cancers are due to human papillomavirus, substantial proportion of anal cancers are related to HPV etiology. Majority of vaginal cancers associated with HPV etiology. A smaller fraction of penile, oropharyngeal, and vulval cancers are due to human papillomavirus infection. When you look at HPV-associated cancers in India, HPV-associated cancers contribute to 7.5% of all cancers. That is quite a large proportion. Among women, cervical cancer is the most common. Men, oropharyngeal cancers are most common HPV-associated cancers. And looking at the trend, HPV-associated cancers are set to increase in the coming years, and there's a projected increase of up to 1,21,000 by the next year or so. I'm giving you all this background as to strengthen my point for the need for HPV vaccination. So Dr. Anandanarayan talked about this cervical cancer, second most common cancer among Indian women, and the second most cause of death due to cancer among Indian women. We talked about primary prevention, we talked about secondary prevention, and Dr. Anandanarayan talked about how a combined approach can expedite elimination of cervical cancer. You've heard about 90-70-90, and I purposely skipped the slide because you must have heard of this since 2020. What we know so far about HPV vaccine, these are prophylactic vaccines. They were approved in 2006. And the basic tenet is to prioritize immunization before initiation of sexual activity and subsequent exposure to human papillomavirus infection. The serological response after vaccination is far superior to any immunity derived from natural infections, and they are as high as 1 to 4 logs, and they are found to be clinically effective against cervical and vulvovaginal diseases, HPV-related anal disease and oropharyngeal disease, and penile cancer. So we're just not preventing cervical cancer by vaccinating girls and boys against HPV, but we're also preventing anal disease, oropharyngeal disease, and penile cancer. What do we have so far? In the market currently, we have the bivalent vaccine, the quadrivalent Gardasil vaccine, and the nanovalent HPV vaccine. They're all recombinant vaccines. The bivalent vaccine has virus-like particles against L1 epitope of 16 and 18 HPV virus. Quadrivalent covers 6, 11, 16, 18. The nanovalent covers 6, 11, 16, 18. In addition, it also covers 31, 33, 45, 52, 58. And we have the new kid in the block. We have the Cervac vaccine, which was manufactured by the Serum Institute, and it covers 6, 11, 16, and 18. We have this vaccine schedule since 2006. Initially, we started with age 11, but then we realized we can start vaccinating our girls from 9 years of age. And from 9 years to 14 years, up to the 15th birthday, we can give them 2 doses of vaccine, 6 to 12 months apart. Later on, from age 15 to 26, we can still provide them with catch-up vaccination. And at age, we recommend 3 doses, 0, 1 to 2, depending on the vaccine given, and then again at 6 months from initiation. WHO has, considering cost, effectiveness, their target population is 9 to 14 years girls, and they consider the rest as secondary target population. These include girls aged 15 years or boys, but this group has to be targeted only if this is feasible, affordable, cost-effective, and does not divert resources from the primary target population or from effective cervical cancer screening programs. In HIV-positive children, we don't provide them with 2 doses, but we vaccinate them with 3 doses. And women more than 26 years of age till 45 years of age, we vaccinate them only after appropriate counseling. So I want to talk a little more about vaccination beyond 26 years of age. FDA has approved expanded use of Gardasil 9 to include women older than 26 but less than 45. But the Society for Gynae-Oncology, the European Society for Gynae-Oncology, the American Cancer Society, and FOXI recommend that women more than 26 years should be vaccinated with an understanding that vaccination does not protect them against already acquired infection, and screening must continue. When I checked at the Indian Academy of Pediatricians in 2020-2021, they still permitted catch-up vaccination up to the age of 45, but WHO primary target group is girls aged 9 to 14 years because they are the ones who best mount immune response, who have not acquired any HPV infection, and hence their immune response is much higher. In women aged more than 26, the primary focus should be on screening much more than vaccination, and vaccine acquired immunity is not as cost effective as compared to screening. And hence, the recommendation in this age group is vaccination after shared clinical information. We look at the vaccine policy in India as per the FOXI, as published in 2020. They also recommend, similar to the WHO, that the primary target group should be girls, and they don't recommend vaccination in boys in the current Indian setting. The preferred target age group is 9 to 14 years, the 2-dose vaccine, and women or girls more than 15 years should be considered for catch-up vaccination only if resources are available, and the vaccine strategy in them is 3 doses. As against all this, when we see rape victims, sexual assault survivors, they should be given a 3-dose course of HPV vaccine, the first dose be given at the time of initial examination. Similar to the WHO recommendation in other bodies, FOXI recommends that the first priority in women aged 25 to 45 years should be cervical cancer screening. And cervical cancer screening and HPV vaccination are not mutually exclusive in the sense like once they are vaccinated, it does not mean we can stop screening. Screening should continue. Despite all this, though the vaccines received FDA approval in 2007, we look at the global uptake of HPV vaccine. In some countries, it's as high as 80%, say Australia. But in low-income countries and low-middle-income countries where cervical cancer is the leading cause of death, global coverage of HPV vaccine is only 15%. And there's been much concern about this. And I mean, when you look at just single-dose vaccine, even those rates are still as low as 15%. So when we look at real-world challenges in low-income countries and low-middle-income countries, cervical cancer elimination seems to be a far cry looking at the current scenario. There are very many barriers to HPV vaccination in low-income countries and low-middle-income countries. There's inequity of access. Cost of vaccine was mentioned earlier in service delivery. There's lack of prioritization in this group because we have other vaccines here, diphtheria, pertussis. Challenges of vaccinating adolescent girls is quite real because many parents have this thing of vaccine hesitancy, shortage of supply. And we need to overcome challenges and proposed ways to overcome these challenges is that we innovate in the vaccine market. And we have the newer vaccines in India, like the CERVICAL vaccine. We innovate vaccine products, like we make sure our vaccines remain, can survive despite the cold, even if they're out of the cold chain by having controlled temperature chain. We innovate in dose and schedule. I'll talk about it later. One thing is single dose and increasing the interval between vaccine. We can innovate in programs providing vaccination because if you can start school-based vaccination, most of these challenges of vaccine hesitancy, acceptance is much better. We need to invest both at the global and national level. We need to integrate with adolescent healthcare. We need to provide information and we need to influence our leaders. So this presentation is to talk about the recent updates and guidelines which overcome these challenges. We look at the history of HPV vaccine studies and implementation in India. In 2008, we had bivalent and quadrivalent vaccines licensed in India. In 2009, there were 2 HPV projects. One is the post-licensure demonstration projects in Andhra Pradesh and Gujarat. And in India, we had the IARC in collaboration with WHO, which wanted to study 2 versus 3 doses of HPV vaccine in India. In the 2009 post-licensure demonstration projects in Andhra and Gujarat, they were designed to address operational feasibility and acceptability of school-based versus community vaccination. Unfortunately, there were 7 deaths reported in this project. And in 2010, the government of India suspended all HPV vaccination research projects. And this stopped the other study, the WHO IARC study in India. So what started as a randomized controlled trial to study 2 versus 3 doses of quadrivalent HPV vaccine resulted in, by default, 2-dose default and a single dose default group. And they had recruited most of the patients, most of the girls in the first year itself. And they continue to follow up these groups, these default groups. And they published their first study in 2017 we showed that the single dose vaccine had non-inferior immunogenicity. When we talk about vaccine trials, we talk about immunogenicity. When you're looking at the immune titers, we look at efficacy. Efficacy in the sense like reduction in CIN-related infections. These are on trial situations. What we talk about in real world is effectiveness. So in 2017, they came with their first publication about immunogenicity, and they found that the immunogenicity provided by the single-dose vaccine was non-inferior to 2 or 3 dose vaccine, but that publication actually supported the 2-dose vaccination in girls more than 16 years of age. In 2021, they came up with this, the results, the follow-up results, 10 years from the initiation, and it showed that single-dose vaccine had 95% efficacy, and they also showed that it showed similar protection against persistent infection from 16 and 18 genotypes. Response was nearly 70% of cervical cancers. That provided by 2 or 3 doses. There was another trial which has happened in Costa Rica, which showed that more than a decade after HPV vaccination, single-dose vaccine efficacy against HPV 16 and 18 remained stable. And there was evolving evidence from randomized controlled trials. We looked at the Tanzanian trial, which looked at one versus 2 or 3 doses in girls aged 9 to 14. And it showed that it showed a robust immune response up to 24 years of age. This is another randomized controlled trial in Kenya, which looked at vaccine efficacy against, which showed good vaccine efficacy as compared to the bivalent and the nanovalent studies. Now, these studies provide robust evidence that even in African countries, which both these countries, both Kenya and Tanzania, are malaria endemic, and we realize that these girls still mount good vaccine response. This came about a month ago, which compared the Tanzanian trial, which looked at young women aged 15 to 20 years, and compared it with the girls recruited in the Kenya trial, and they performed immunobridging analysis. They showed that the immune titers were similar across all age groups, be it 9 to 14 or 15 to 20, and showed that a single dose vaccine shows similar response in both these girls. So in 2022, after the initial recommendation by SAGE, in December 2022, WHO recommended that a 1 or 2 dose schedule for girls aged 9 to 14, a 1 or 2 dose schedule for girls and women aged 15 to 20, and 2 doses with a 6-month interval for women older than 21 years. Now, there is a clause to it. These are off-label recommendations. The sense like these are not recommendations by the vaccine manufacturing communities. We don't have evidence about efficacy from those randomized controlled trials. We still have to study their efficacy. We still have to study the effectiveness. But this seems to be a major game changer to consider cost. If you can consider cost, we don't have to follow up girls to get them back for their second dose. And it's easy to implement in low income and low middle income countries. But this is not the recommendation for immunocompromised or those who are HIV infected. So as I mentioned earlier, a single dose vaccine has great potential to accelerate introduction to reach the 90% goal of vaccinating all girls less than 15 years. It simplifies delivery, reduces the potential for supply shortages, and we can achieve our targets soon. Another news we probably heard about 2 years ago is the launch of the Serum Institute, the quadrivalent vaccine manufactured by the Serum Institute in collaboration with the DBT and BIRAC and Bill and Melinda Gates Foundation. And they proposed, when they launched in 2022, a cost of 200 to 400 rupees per dose. And this was to be funded by the Indian government, and the initial target were girls aged 9 to 14 years of age. Last year, the Serum Institute published their evidence in Lancet, and they showed a 100% seroconversion rate, be it in girls 9 to 14 years of age, or boys aged 9 to 14 years of age, or in women aged 15 to 26 years of age. They also showed non-inferior geometric mean titers when compared to the quadrivalent vaccine in girls aged 9 to 14 years of age and boys aged 9 to 14 years of age. And they concluded that the serum vaccine, the CERVICAL vaccine, showed a non-inferior immune response in girls and boys aged 9 to 14 years of age and an acceptable safety profile compared with the Gardasil vaccine. So what are the current recommendations in light of what I had spoken earlier? So if a child is brought to your clinic, or this is an opportunistic vaccination, 9 to 14 years of age, 2 doses, 6 to 12 months apart. Age 15 to 26 years or immunocompromised children, say this child has SLE and is on mycophenolate, or this is a HIV positive child, then 3 doses, 0, 1 or 2, depending on what vaccine you give, and at 6 months. Adults, 3 doses, 0, 1, 2, and 1, 0, 1 or 2, and 6 months. So what we have for girls, we have Cervarix, we have Gardasil 4, we have Gardasil 9, and the CERVICAL vaccine. But for boys, we don't have the quadrivalent vaccine, we have the nanovalent vaccine and the CERVICAL. When we look at all the costs, CERVICAL, when not procured for the government, comes to about 2,000 rupees. Gardasil is about 3,700. Gardasil 9 is about 10,000. CERVICAL comes to about 2,000 odd to the provider. Now, that is opportunistic vaccination. But when you talk about vaccination strategies at national level, regional level, policymakers, and if you want to make sure we cover all girls or boys in the vaccine primary target group, 36 countries have now adopted single-dose HPV vaccination schedule. Countries like Australia, Ireland, which are almost close to cervical cancer elimination. A lot of South American countries have adopted single-dose HPV vaccine. Brunei, Rwanda have also adopted single-dose HPV vaccine. Now, the single-dose HPV vaccine is off-label. As I mentioned earlier, this is not by the manufacturers, but by regional bodies. So if you're looking at starting a vaccination program for a school or a vaccination program for your district, what we can consider is a 1-dose or a 2-dose schedule for girls aged 9 to 14 years, 1 dose or 2-dose schedule for girls and women up to 20 years of age, but more than 21, what is suggested is 2-dose with a 6-month interval. But this does not apply for HIV positive children or those who are immunosuppressed. To conclude, early this year, we saw this announcement by Mrs. Srimati Nirmala Sitharaman, who said that the government will encourage vaccination for girls. The primary target group, we have yet to see this in fruition, but many districts have taken up in Kerala, in Tamil Nadu, Punjab, Sikkim, Delhi, and we need to adopt HPV vaccination. When CERVICAL came, Lancet called it the silver bullet that saves life. And let's join hands and vaccinate, starting with our kids first. Vaccinate our nieces, our nephews, and grab every opportunity to vaccinate the children of the women that we see in our own. Thank you.
Thank you, Dr. Vinoda, for such an excellent and informative talk. As she said, now most of the WHO strategy is mainly focusing on single-dose vaccination schedule based on most of the RCTs also support this fact. And by this, actually, we can spare the vaccines and it will reach in more number of girls and we can achieve the target of 90% vaccination at the age of 15 years as early as possible. Thank you, Dr. Vinoda. I would like to invite Dr. Jeena Baburaj, Madam. Madam, please, a few valuable comments on this session. These are past Oncology Committee Chairperson. Jeena, Madam.
Thank you, Adarsh. and the organizers for giving me this opportunity. Dr. Vinodha, your talk is excellent. You have completed everything about the vaccination schedules. So there's a confusion about 1 dose or 2 dose vaccination for the girls up to 9 to 20 years, I think. Apart from the primary target groups, it's 9 to 14 years, but we can give up to the WHO's latest the guideline says we can give, you already said that 1 dose up to 20 years. So this 1 dose means we can cover a lot of people, lot of children with this 1 dose schedule. But the problem is it is not it's not the study given by the vaccine people. But in India, the major studies from India shows that all these 1 dose, 2 dose, and 3 dose schedule, the antibody titer is almost equal after 2 years. So I think we can adopt this 1 dose schedule in our private patients. For a public view, we can't say like that, because in the leaflet it shows that 2 dose and 3 dose schedule. So our own people for personal patients, we can adopt this 1 dose schedule. And one I object with you, Vinodha, is that FOXI GCPR recent, that is 2023 GCPR, that recommends that we can give the vaccination up to 27 to 46 years. That's a level 2 and grade B recommendation. So up to FOXI also recommends up to 46 years, but more importance should be given to the screening procedures. So if they are insisting us, we can give with the...
Yes, ma'am. I didn't say we can't give. It is after shared decision making. That's what I mentioned.
Yeah. FOXI GCPR also it says.
Yeah, so it is after shared decision making, realizing that it is important to be screened more than vaccine.
And then we will promote this vaccine. One thing you said that we should vaccinate our own children and start from our family. For Kerala, our vaccination is very less previous years. For 2021, before 2021, our vaccination is around 50 vaccines per month. But initially, we have given by this gynecology sensitization. So we have done a lot of public awareness programs. After that, now the vaccination is more than 1,000 vaccination per month in Kerala. That is the statistics today. It is more than 1,000 vaccines are going. In Kerala, we are
really great, because I was looking at
from 50 vaccines per month, we jump into more than 1,000 vaccines per month. That is because of the gynecologists, all the gynecologists in Kfog, they all work together and they spread the message. So the public is ready to accept it. And once it comes into so if the government introduce this vaccination, then not much, I think there's not much rejection for vaccine. This anti-vaccine will be less. So this is what I want to. And some people say that there is an infertility against anti-vaccine. Lobbies are saying infertility caused with these vaccines and side effects. As far as there is not much side effects, just like a TT injection only. And Cervarix vaccine is not available in India at present. Cervavac and Gardasil 9, Gardasil 4, all these are the 3 vaccines. At present, it is available in India. So,
thank you, madam. Okay, then we'll move to chairpersons, Dr. Naik from Malabar Society. Sir, please.
So thank you, Dr. Vinodha, for excellent speech. And it contains how to prevent most of the cancer in the age group up to 26 years. So we have to hit on the head with the nail. Target the target group that is less than 14 years, from 9 to 14 years, and even up to 46 years we can treat. We can give the vaccines, I think so. And so these type of webinars are very important for us to for the awareness and to treat the patient and to prevent the cancers in the society. Thank you, madam.
Dr. Anjali from Malabar Society.
Good evening, madam. Very nice, excellent presentation, crisp and clear guidelines. I also agree with you that hitting them early, targeting the younger generation from school age, and school-based vaccination programs will help us in a great way in bringing about higher vaccine coverage. Also, the government's initiative to include HPV vaccination helping us in the long run. There is one question from the chat box. Is Cervivac recommended about 26 years of age? I think you can answer that now.
Yes, ma'am. I have typed it in the chat box. We don't have studies beyond 26 years of age. We have, I think they are planning to study that and also look at other various, those studies are still awaited. So we can give it, but we should tell them that we don't have evidence as yet beyond 26 years of age.
Yeah, I think from the brand's point of view, from the company point of view, they haven't recommended, but then we have other guidelines from WHO and all that after discussing with the patient and telling them about the importance of screening and counseling them that screening is also more important even after vaccination. We need to decide according to the patient's decision also. I think we all agree on that.
Yeah. Yeah. I agree.
Okay, ma'am. Thank you so much.
Okay, thank you, chairpersons. Now we are moving on to the next session. Update on management of CA cervix. The speaker is Dr. Shruti Sivadas. So happy to announce her name. She was my immediate senior while I was doing my PG in Trivandrum Medical College. Welcome, Shruti Chechi, for this session.
Chairing the talk, we have Dr. Kamappa sir, who is the Chief Gynecologist in New Alma Hospital. He did both his UG and PG in Calicut Government Medical College. Also chairing the session, we have Dr. Srija ma'am, who is a consultant gynecologist, District WNC Hospital, Palakkad. Welcome you both, ma'am.
Hello. Thank you, Adarsh. Thank you, Chair, for the lovely introduction. Yes, Adarsh, we are alumni of the same college. Yes. So I will share the slide. This is top left. I don't know. I hope the slide is visible. Okay. So good evening, respected chair, as well as the audience. I am a Malayali myself, as Adarsh has told. So I am very much grateful for the KFOG Oncology Committee for giving me this occasion to have a privilege to be in front of a home state audience. So moving on to my topic, which is update on management of carcinoma cervix. This is a little long topic, and I think my slides might be a bit extensive. So I hope that time might not be a problem. So these have already been discussed by the previous two speakers. I just want to stress that cervical carcinoma continues to be the second most leading cause of cancer deaths among women in India, despite the fact that it is largely preventable at 3 levels, primary, secondary, and tertiary. The first two have already been discussed. So my topic pertains to the tertiary, that is the treatment of invasive carcinoma. So this is particularly important because this is a graph from the WHO 2020 update on the Indian scenario of CA cervix, and it shows that there is the majority of the bulk of the cervical disease burden is shared by early and locally advanced cervical carcinoma. So this is a good thing because this is a point where we can intervene and significantly reduce the disease prevalence as well as the morbidity. So my presentation today will be largely fashioned around these major topics.
And I'll also be talking a bit on some of the recent advances in approach to the surgical management. So first and foremost is so I will be talking on whatever the updates regarding the management. So the first and foremost is the change in the FIGO staging. With FIGO, the initial staging was the 2009 staging, and that was an entirely clinical-based staging. But later on, FIGO, the same authors were analyzed large databases of cervical cancer and found that a clinical-based staging has a lot of drawbacks. So they came to the conclusion that nodal disease as well as tumor size are major contributors, major predictors of disease survival. And so based on these, the main changes were approved. So the main changes are in these three stages. The most important is stage 3C was included, which included nodal disease based on either radiological or pathological staging. Then was that the stage 1B1, which included initially up to 4 centimeters, was split into 2 centimeters and more than 2 centimeters, because less than 2 centimeters had a significantly better survival than more than 2 centimeters. And stage 1A, again, width was also a factor which was included in the definition of stage 1A, and that has been removed because it had no particular significance as far as prognosis was concerned. In fact, it just increased the pathological processing time. So just moving on to the different stages. So stage 1 is basically disease which is confined entirely to the cervix, and this has both two spectrum, one disease which is microscopically seen, which is stage 1A. So the important point I'd like to convey here is that this is a disease which has to be diagnosed by a cone biopsy. So when a cervix looks grossly normal, you will not be able to, if a punch biopsy that you take from somewhere, you might be missing an invasive disease somewhere else or a more micro-invasive disease somewhere else. So this is a stage which is proven only by a cone biopsy or an incidental hysterectomy specimen. So this includes up to 5 mm disease, and whatever comes more than 5 mm in stromal invasion goes to stage 1B1. So 1B1 is a heterogeneous spectrum composing of both microscopic as well as gross residual disease. And the difference is in the splitting of 1B to 1B1 and 1B2. So as you can see, so this is early disease. So early disease includes up 1A, 1B1 and 1B2. 1B3 has been clubbed along with locally advanced cervical carcinoma for management and prognostic factors. So in the early disease, as we can see, the depth of stromal invasion is a major factor contributing towards lymph nodal disease. And invasion of the lymphovascular space correlates with the parametrial invasion. So these two factors are a major determining thing. So these help us in determining the whether we have to do a lymph node dissection in early stage, as also how the extent of radical dissection in an early stage disease. And up to, as I've already told, 1B1, 1B2 are early disease, and 1B3 is clubbed with locally advanced cervical carcinoma. So coming to stage 2, so stage 2 and stage 3 are diseases which are beyond the cervix. So stage 2A is disease which has involved the upper vagina with sparing the lower vagina, whereas stage 3A is disease which has gone all the way down to the lower vagina. Stage 2B is disease which involves the parametrium but not up to the pelvic side wall. And stage 3B is disease which involves the pelvic side wall or is associated with a non-functional kidney or cross HUN. So the new addition here is the stage 3C disease, wherein you have lymph node involvement in the pelvic lymph node area as well as the parietic lymph node area, and that is split as 3C1 and 3C2. C1 for pelvic and 3C2 for parietic. And this again has a further annotation as to whether it is a radiologically staged, meaning whether it is a diagnosis from an imaging such as CT or an MRI or a PET, or whether it is a pathological staging after a surgery or the biopsy or an FNAC of a radiologically suspicious node. And stage 4 again has locally advanced cervical carcinoma, which is stage 4A, as well as metastatic disease. So stage 4A is involvement of the bladder or the rectum. So this is also classified under locally advanced cervical carcinoma, along with 1B3, 2A2, and the remaining. And metastatic disease, and stage 4B is an entirely metastatic disease where there can be metastasis either to the lung or supraclavicular lymph node or the groin node, and so on. So as I've already mentioned, FIGO 2018 has significantly added imaging as a major contributor towards the staging process. So it can be CT, MRI, or a PET CT, or simply an ultrasound scan. And the pelvic MRI is ideal in early stage disease, especially in fertility sparing surgery. And when you want to assess nodal disease and metastatic disease, especially from stage 1B1, a whole body CT scan or a PET CT is advised. And cystoscopy and sigmoidoscopy are indicated currently only if the patient is symptomatic. And when you are suspecting, you have to prove it by a biopsy by any of these manners before you label it as a stage 4A. So just a submucosal infiltration does not label it as 4A or an edema. It has to be biopsy proven mucosal infiltration. Now, moving on to the management of early CS cervix. So as I've already said, so early carcinoma is 1A up to 1B2 and then 12A1. So 1B3 along with 2A2 move to locally advanced cervical carcinoma. So before I move on with the further slides, this is just a short slide because of time constraint, I will not be elaborating on the surgical procedures. So this is the minimum procedure that we do in early stage. There's a cold knife cone. So a cold knife cone is basically an excision of the transformation zone. The next procedure, this can be done either by a cold knife or a LEAP procedure, or there are carbon dioxide laser and straight wire, but those are not generally recommended. And then you have a simple trachelectomy is a slightly higher procedure. It's like the lower part of a simple hysterectomy. So you're removing the cervix, retaining a small portion of the upper cervix, and just whatever is the adjoining vagina and the parametrium. And the next one would be a radical trachelectomy. So the radical trachelectomy is the lower part of a radical hysterectomy. So you are going to remove the cervix along with some amount of the parametrium, which can be half of the parametrium or up to the pelvic side wall, along with upper 1/3 of the upper 1 to 2 centimeters of the vagina. And radical hysterectomy, here and I mean the type 3 radical hysterectomy, where we will be removing the entire uterus along with the parametrium up to the pelvic side wall and upper 2 centimeters of the vagina. So these are the procedures we will be encountering in course of the management. So management of early stage disease, stage 1A. So have to remember this is ideally, has to be a cone diagnosis or a diagnosis from an incidental hysterectomy. So we are considering a situation where there's a cone diagnosis and the uterus is in situ. So here in the patient, these patients are usually younger patients, so they have the option of either a fertility sparing procedure or a fertility non-fertility sparing procedure. So in a fertility sparing procedure, as I already mentioned, the stromal invasion is associated with lymph node involvement and LVSI is associated with parametrial involvement. So based on that is how you decide what to do. So if there's a 1A1 without LVSI, a cone should be enough. In a 1A2, because there's a stromal invasion, even if there's no LVSI, you have to do a lymph node evaluation, which can be a sentinel or a complete lymph node dissection. And in either stages with whenever there is an LVSI, there is a risk of parametrial infiltration. So the dissection has to be radical. So in a fertility sparing situation, that would be a radical trachelectomy. In a non-fertility sparing situation, in the same situation, a cone would be replaced by an extrafacial hysterectomy and a radical trachelectomy will be replaced by a type 2 radical hysterectomy. So there are radiotherapy options also in patients who do not want to preserve non-fertility, at the same time do not want to have some comorbidities which are interfering with the surgical procedure. So I will not be detailing on that. Now coming to the management of the remaining early stage disease, which is 1B1, 1B2, as well as 2A1. Here again, fertility sparing and non-fertility sparing options are there. So here, traditionally the management has been a radical trachelectomy with the lymph node evaluation, either in the form of a sentinel or a pelvic lymph node dissection. However, recent studies have shown that it is possible to do a conservative cone biopsy along with the lymph node evaluation if these criteria are met. These are based on a study called the CONSERVE study. Most importantly, the stromal invasion should be less than 10 mm and it should be a favorable histology. So the non-fertility sparing options, as I already mentioned, instead of radical trachelectomy, it would be a radical hysterectomy with a lymph node dissection, and a parietal lymph node dissection is now optional up to the level of the inferior mesenteric. So in such cases, the only thing you can do is do an ovarian transposition, and then salpingectomy is also advised at the time of the ovarian transposition. In order to just simplify, the ESGO has just made it very much simpler because any 1A tumor with or without LVSI, you just do a cone, and in a 1B1, only if it's LVSI positive, a radical trachelectomy is a must. Otherwise, a cone or a simple trachelectomy is sufficient. Coming to the management of locally advanced cervical carcinoma, so that is again 1B3, 2A2, as well as 2 to 4A. So of these, this is very simple. These are managed by definitive CCRT. This is the only one which is a heterogeneous group, which is managed by either surgery or non-surgical management. So surgical management is radical type 3 hysterectomy with a lymph node dissection, and a para-aortic is optional. And the non-surgical management, as we all know, is a definitive concurrent chemoradiation therapy, which consists of a pelvic external radiation with a concurrent platinum, followed by brachytherapy. And it has to be preceded, a definitive CCRT should always be preceded by a whole body CT or a PET CT. So how do we decide between the two? So the decision is based on patient counseling. And the advantages that surgical procedure offers is that one is a psychological relief, and there's a surgical specimen to tailor adjuvant, and there's less radiation damages to the vagina and the chance of ovarian transposition. So because of these are generally preferred in younger women, patients with ectocervical growth more than endocervical growth, because ectocervical growths are associated with the lesser chances of risk factors in the final specimen and lesser chance of going for a combined modality treatment. So what has to be remembered in these two stages, because these two stages, it is very equivocal. You can go either this way or that way. But at the same time, these stages are also associated with high rate of patient ending up receiving an adjuvant radiotherapy based on the operative histopathology report. So it is very important that you should, as much as possible, avoid a combination of a multimodality treatment, that is surgery, chemoradiation, chemotherapy, and radiation, because there is a trial which has shown which has discussed about the extensive morbidity associated with the combined treatment. So here, proper case selection and preoperatively counsel the patient extensively and preparing her for the possibility of a combined treatment is a must before you take a decision for a surgical management. Now, management of the other stages from stage 2 to 4A, definitive treatment is always CCRT, that is concurrent chemoradiation therapy, except for a selected cases of 4A where eccentric procedures might be feasible. And before the procedure, definitive radiological imaging with PET or whole body CT is a must. Surgical paraaortic lymph node dissection for the purpose of staging to decide on the extent of radiation is also a new thing which has come up and which is optional as per both the major guidelines. Now in 3C1, 3CR, which is the radiologically lymph nodal disease, again, the definitive management is CCRT. It is just that between the two, the field of radiation differs significantly. And to decide on the field of radiation, either with the pelvic RT is sufficient for a pelvic lymph node with lower para-aortic coverage, or you can go for a surgical staging of the para-aortic lymph node to decide to make sure whether you want to extend the field or not. And 3C2R is definitely an extended field external RT to cover the para-aortic area as well. So just summarizing the stages, the early disease, here and there you have the option of fertility sparing surgeries and less radical procedures, and these are based on your stromal invasion and LVSI because they will help you with whether the lymph node is involved or parametria. And locally advanced disease, predominant treatment is CCRT. And the only kind of thing comes in 1B3 to 2A2 where you have to decide which way you want to go. And metastatic disease, here the aim of treatment in all the other stages, the aim of treatment is curative, but in metastatic disease, the aim of treatment is palliative. And all your treatment, be it chemotherapy, radiotherapy, or immunotherapy, is aimed at palliation. Patient might need some surgical procedures like diversion. Now, I list a few approaches which are variants in the general treatment. So one is the role of minimally invasive surgery. As we all know, you would have all heard about the LAC trial, which came out in 2018, and based on which the NCCN as well as the ASGO recommended that it is radical procedures should be done only via the open abdominal or the laparotomy approach. But is this an end to MIS? So the LAC trial was further, the post-hoc exploratory analysis of the LAC trial showed that there were a lot of drawbacks with respect to surgical proficiency and pathological reports and heterogeneous study group. And after that, several retrospective studies have shown that it can be safely performed with low recurrence rates and low death rates if you have if you're selective in your tumor selection, as well as make sure that the tumor spillage during the laparoscopic procedure are less. So, the ESGO-ESTRO guideline in 2023 actually says that MIS can be considered if the tumor is less than 2 centimeters and there is a preoperative cone with a negative margin in a high volume experienced center, and the patient is extensively counseled about the current evidence. So which are the possible patients that you could choose for MIS? Restrict the criteria to less than 1B1, ideally a preoperative cone biopsy. And if the cone biopsy is not being done, make sure that the tumor spillage during the laparoscopy is minimized at the time of colpotomy by a mucosal suturing prior to the colpotomy from the vagina. Avoid a uterine manipulator. And some authors have said that robotics might be associated with a lesser recurrence rates when compared to laparoscopic surgery because the parametrial resection during robotic surgery might be better. So there are ongoing trials comparing them. The next concept is de-escalating radicality, meaning the main problem with radical hysterectomy is the morbidity associated with the lateral extent of the resection, lateral anteroposterior extent of the resection. So but there have been several trials in more advanced stages of disease like 1B and 1B up to 1B3, but they have a heterogeneous group and there's no particular consensus on that. So the authors have now come down to focusing on earlier stages where, they have younger patients and morbidity is more important, lesser adhesions, less dissection, less morbidities. So they have come down to focusing on stages 1A2 and 1B1. So in these are the two main trials. And based on these trials have shown that simple hysterectomy may be as safe as a radical hysterectomy in these particularly chosen patients which meet all these criteria after a cone. Or conization can also be done in the place of a radical trachelectomy if these criteria are met. And this has been included in the NCCN guidelines, and I have mentioned it earlier. And this trial says that simple hysterectomy with PLND is as safe as radical hysterectomy with PLND, again in 1A to 1B1 disease with minimum stromal invasion, which they do not necessarily need a cone. It can be a less than 50% invasion with MRI. The next concept is the concept of sentinel nodes. So if there are residents in this audience and who are not aware of what the concept of a sentinel node is, so a sentinel node is the first node to receive lymphatic drainage from a particular organ of interest. So if that organ of interest develops cancer, this is also the likely node to get the first lymphatic metastasis. So instead of doing an entire pelvic lymph node dissection, you can focus on removing of the sentinel node alone and thereby reduce the morbidities both early and late associated with the pelvic lymph node dissection. So this concept is most studied in a female genital tract and vulva. Cervix is relatively less studied, probably endometrium is ahead. So the NCCN recommends that it can be done up to 2 centimeters, and any of these methods can be used. ESGO recommends that a central lymph node alone to be done only in stage 1A disease. In more advanced disease, when central lymph node is done, it is done only for the purpose of an intraoperative frozen section to decide on whether to abandon the procedure or not. And once the sentinel is negative, you have to go for a full pelvic lymph node dissection. The next concept is the downsizing of the tumor. So this is herein where, a big tumor, downsizing by giving a neoadjuvant chemotherapy, there are 3 main scenarios. So one can be when a patient who cannot be operated is for RT wants to be converted into an operable patient. Second may be an operable patient who wants a reduction in radicality. And the third may be a fertility preserving, non-fertile patient who wants to preserve fertility, but is not an ideal candidate for fertility preservation. So in the other 2 scenarios, there are various studies which still have no conclusion, no recommendation, no guidelines for the same. But regarding the fertility sparing surgery option, ESGO 2023 has mentioned that there are studies up to for tumors more than 2 centimeters, and there may be an option, but there is no definitive consensus on what regime and how many cycles and what the adjuvant is. So, but what they do mention is that in such cases where you're planning to give an NACT to downstage a fertility sparing patient, so in that case, you have to do a pelvic lymph node dissection prior to NACT to confirm that the patient can go ahead with NACT. Coming to the adjuvant therapy, I don't want to stress too much. So adjuvant, most important you remember is that your patient selection has to be good when you go for surgery. Minimize the adjuvant therapy is most vital. So adjuvant therapy is based on tumoral factors, the intermediate risk factors, and the high risk factors. If any of these high risk factors are there, patient invariably has to go for a concurrent chemoradiation as an adjuvant in addition to the surgeries. This is a multimodal treatment. Here again, RT is the current recommendation, but there are various authors who have questioned whether RT is needed at all in the presence of intermediate risk factors. So there's an ongoing trial to examine the role. And coming to updates in the therapeutic management. So I'm not detailing on RT because there is a speaker after me, but there's no medical oncologist I observed. So I've just documented there's no particular advances in chemotherapy, but with respect to targeted therapies, there have been. So bevacizumab is recommended in advanced recurrent metastatic disease along with chemotherapy from 2014, and pembrolizumab, which is an immunotherapy, has also been recommended, FDA approved in 3 different settings, including the first-line setting with concurrent CTRT in advanced disease, and also in the persistent metastatic disease, either in combination with the palliative chemo and Vivac, or as a monotherapy when all chemotherapy lines have failed. And just 2 slides on the updates in pathology. So now you should know that the current WHO 2020 classifies these carcinomas into HPV-associated and HPV-independent, both squamous cell adenocarcinoma, and these are based on P16 immunohistochemistry, HPV testing, or the in situ hybridization techniques. And why they generally have a poor prognosis, older age of presentation, more nodal disease. But there is no definitive difference in management based on these. And adenocarcinomas are known to have a very poor prognosis with low numbers, less studied, and people are not sure how to manage. So there have been invasive patterns also studied pathologically, and has been found that Sylvia patterns B and C are associated with poor prognosis, and in pattern C, an extensive lymph node dissection and a radical surgery is preferred over a central lymph node and a less extensive surgery. So the take-home message, I have just a few slides. HPV-based classification, whenever feasible, if not possible, it is labeled as NOS, not otherwise specified. And the latest staging of 2018 is a clinical radiosurgical staging. Imaging is allowed, and management is based on stage and the patient desires. In non-fertility sparing situation, the aim is to avoid a combined to achieve cure, a combined modality treatment. And so patient selection is extremely important, and patient counseling has to be perfect. And aim of fertility sparing surgery is to get a negative margin, and cone is acceptable in 1A disease as well as without LVSI, and with LVSI, radical trachelectomy is a must in 1B1. Sentinel lymph node can be safe in selected cases if the algorithm is adhered in a well-validated center. And NSET pre-surgery is not an established practice and should be highly selective and individualized. Thank you.
Thank you, Dr. Sudhir, for such an excellent talk. So I want to add a few points like that. As she told, lab trial actually we didn't show any benefit, or it was inferior for the management, surgical treatment of CS cervix. Even though it has a lot of flaws, it was a poorly designed trial. We need a proper RCT to support or to initiate MIS and CS cervix. Anyway, still in some other situations, we can use this modality, especially as she told before, suppose in a 1B3 tumor, CS cervix, when we do surgery, before going for a vertical incision, actually we can put your scope and you can see, open the peritoneum and see any significant or suspicious nodes are there. And you can take these nodes and send it for forceps section. If it is positive and you need not go for a surgery and she's a candidate for CTRT. Actually, if we open the peritoneum, actually it will add on to the toxicity. And this situation is in case of neoadjuvant chemotherapy. In such situations, even pregnancy, even though the evidence are not that good, even pregnancy in second trimester and all, we can give neoadjuvant chemotherapy and get to plan the procedure. In such situations also, you can, before starting neoadjuvant chemotherapy, actually we can assess the nodes. If we can send the node and it is positive, then we can label it as a locally advanced disease. Thank you for the session. I invite Dr. Kamappa sir for his valuable comments on the session. Sir, please. Okay. Dr. Srija, madam.
President, thank you. First of all, I thanking Kfog for giving me the opportunity as a chairperson, and it was very good talk on latest management of the carcinoma cervix. Madam, I want to know about how will you follow up a patient? Young patient comes to stage 1A CES service, and you are advising cold knife conization, and how will you follow up that patient?
So such a patient, so first thing that we would, as oncologists, we do is that during a whole life conization procedure, we avoid the stumped off sutures so that the cervix is well visible. So we use either the ball cautery or just particular, hemostatic sutures rather than a stumped off suture which completely covers the ectocervix. And the second thing is we prefer, the ideal situation would be HPV as a test of cure, calling the patient for a 6 monthly or a 1 year screening for HPV. And after 2 screens, the patient can go back to routine screening and be on regular follow-up. If not feasible, liquid-based cytology or a conventional PAP without HPV is also an option. So there is no consensus on whether the patient has to go for a completion procedure later.
Thank you. There's a very good talk about the latest management.
Thank you.
Yeah. Thank you, chairpersons. Our next topic is on role of radiotherapy in cancer cervix. The speaker is Dr. Aisha, Gadagiri Hospital, Aliva. Chairpersons are Nishi Roshni from Thrissur and Dr. Anush from Thrissur. Over to you, madam.
Excuse me, is my screen visible?
No.
No, it's not yet visible.
Okay. I hope it's visible now.
No, ma'am.
The screen is not visible as yet, doctor.
Okay, just let me change. Screen sharing button. Screen sharing button. Choose what to share. Let me PPT. So, just a second. This one.
Dr. Aisha.
Just a second.
ശരിയാവുന്നില്ലെങ്കിലേ ഡോക്ടർ കുഞ്ഞുമൊയ്തീന് ഷെയർ ചെയ്യും PPT.
This one PPT.
ഞാൻ പറയുന്നത്.
Just a second. Madam, I'm
സ്ക്രീന് ബ്ലാക്ക് ആയിട്ടാണ് കാണുന്നത്. ഒന്ന് സ്ലൈഡ് മാറ്റി നോക്കുവോ?
Okay, can you see it now? Can you see it now?
No, can't see.
Okay.
ഇപ്പൊ കാണാം.
Okay, okay, ma'am. Okay.
Screen കാണാം. Oh, yes, it's
Okay.
there.
Okay. Is it visible now, madam? Can I continue?
Oh, yes, please continue, please.
Okay. Okay. Good evening, everybody. I'm really sorry for the technical glitch. Thank you very much for the opportunity given by KFOG for giving me an opportunity to talk on one topic where we radiation oncologists are very passionate about. So radiotherapy in carcinoma cervix, because we come in handy in all the stages. Okay. So my talk would go through the figure staging. I think Dr. Shruti has talked to you all about in detail about the figure staging. So no need to start on that. The indications I'd be going through the indications for radical and adjuvant and palliative treatment, the techniques, volume and dose that we give, a word about brachytherapy and the adverse effects of treatment. So this we have already discussed in detail. So to cut to the chase, the role of radiotherapy comes in three stages, which is either radical treatment, an adjuvant treatment post-surgery, or in the setting of a palliative form. So basically, what is radiation or radiotherapy? It's ionizing radiation that you give to cure malignancies, and which is we give through two modes of treatment. It is either teletherapy or an external beam radiotherapy, short for EBRT, and which is given through two types of machines. You would have seen Cobalt 60 machines, which delivers gamma rays, and the later version of radiotherapy machines are the linear accelerator, which gives radiation through mega voltage. We use mega voltage X-rays and electrons.
most of our centers in Kerala have linear accelerators. All the private centers, as well as all our medical colleges, have linear accelerators right now. Cobalt 60 is still in use in some of our government institutions. So Cobalt 60 basically uses a radioactive source, and in linear accelerator, we use X-rays. The other mode of treatment is brachytherapy. Brachy means close, where you put in a radioactive source, either close to the tumor or inside the tumor, to deliver the dose required. This is a picture of a linear accelerator where you have this as a treatment head and the imaging panels and the treatment couch. So coming to the indications, Dr. Shruti has given you a detailed algorithm for stage-wise treatment of carcinoma cervix. I'd like to go through stage-wise where radiotherapy comes into picture. So as you all know, for still stage 2A, the primary mode of treatment is definitely surgery. In stage 1A1, an indication for radiotherapy comes in even if there is no lymphovascular space invasion as in biopsy, but the cone biopsy is margin positive and where a resurgery is not possible, or it is medically inoperable to do a second surgery. There, a brachytherapy has a role. In stage 1A1 and 1A2 with lymphovascular space invasion, if there is medical inoperability, there you can definitely go for pelvic external beam radiotherapy as well as brachytherapy, but there chemotherapy is not indicated. For stage 1B1 to stage 4A, the primary mode of treatment is definitely radical concurrent chemoradiotherapy and brachytherapy. Of course, in the initial, the early stages, there is an overlap for where either surgery or radiation has a role, which Dr. Shruti has also talked about. I'll come to the adjuvant, the indications for an adjuvant treatment in the coming slides. Coming to adjuvant radiotherapy. So surgery up to stage 2A is acceptable primary mode of treatment. And the adjuvant RT, as you know, is based on the Sedler's criteria, which is this, where you go for adjuvant radiotherapy if there is a lymphovascular space invasion in a biopsy, and you need to look at stromal invasion. If it's a deep third invasion, any tumor size, you need adjuvant radiotherapy. If it's a middle third, if it's 2 centimeter or more, and if it's superficial third, if the tumor size is more than 5 centimeter. These three criteria come into picture when there is lymphovascular space invasion. If there is no lymphovascular space invasion, if it's a middle or third volume of cervical stromal invasion is recorded, if it's a tumor size of 4 or more, you go for adjuvant radiotherapy. If you have a positive parametrium, positive node, or a positive margin, these three conditions, you go for adjuvant chemoradiotherapy, where external beam radiotherapy is given. And because the surgery is complete, you have microscopic disease, and you go for an external beam radiation, and you give a dose of 50 gray in 25 fractions for the microscopic disease. And after surgery and after chemoradiotherapy, where chemotherapy is given weekly with injection cisplatin along with external beam therapy, only in these three situations. Brachytherapy after an EBRT in an adjuvant setting is given only if there is a positive margin to reduce toxicity. So coming to treatment volumes are always based on the patterns of spread of the disease. So for carcinoma cervix, there are 3 modes of spread, which is direct spread into the vagina, the parametrium, or into the uterus. Second, by the lymphatic spread into your pelvic lymph nodes, para-aortic, or superiorly into the supraclavicular lymph nodes. Third, hematogenous spread, mainly liver, lungs, or bone. The slide is very important because in our target volume definition or our decision on which all areas to treat depends on this, the stage and the possibility of a pelvic and a para-aortic lymph node. So as you see, as the stage progresses, definitely the risk of a pelvic lymph node. So from stage 1A1, if it's 0.5%, when you go to stage 3, it is 45. Again, for a para-aortic lymph nodes, in stage 3, it's about around 20 to 30%. So when you define target in radiation, so radiotherapy as indicated in when you decide the target, so you look at the main aim is 3. 1, you give a tumoricidal dose or to get a good control for the gross disease, which is the primary with its extensions like vagina or parametrium, and the grossly involved lymph nodes, which is evident from your imaging study. 1. Second, you're giving a subclinical, you're taking care of the subclinical disease where possible microscopic spread can be there surrounding the tumor, according to the pattern of spread discussed earlier. 3, the lymph nodal involvement, and which is definitely according to the clinical finding and the stage of the disease. So in our target, so the entire uterus, the tubes and ovaries, the parametrium, uterine ligaments, vagina according to the stage, and the lymph nodes will be included. The vaginal involvement is, we include 2 to 3 centimeters of uninvolved vagina, which is a dictum. If you have a gross vaginal involvement, the entire vagina will be treated. In case of pelvic lymph nodes, you cover up to from the bifurcation of from common iliac, internal iliac, external iliac lymph nodes. The parametrial and the paracervical nodes will be included as well. Inguinal lymph nodes are included only in 2 settings, where you have either positively involved lymph nodes, or you have a lower 1/3 of vagina involvement. Otherwise, you don't treat inguinal lymph node in radiation. What about the para-aortic lymph node involvement? I'll be showing you the treatment volumes as seen in a CT. Para-aortic lymph nodes are involved, is included in a study if it is grossly involved, 1, or you have disease up to common iliac involvement. If you have gross nodes in the common iliac region, you can include the para-aortic strip 2 in your radiation field. The para-aortic lymph node strip will go up to the D12. Usually, we go up to the infra-renal hilum area, which is D12 to L4, L5 space. The entire para-aortic strip is taken along with the pelvic treatment. The extended field is given only in select situations. Why? Because we can have the target volume is large, and it can result in bowel toxicity. The tolerance to a para-aortic lymph node treatment is not as you expect for a pelvic treatment alone. And you can have the bone marrow is being involved. Of course, with our newer treatment modalities, you can have an extent of control on the bone marrow, on the radiation that bone marrow receives. But since the patient is also undergoing concurrent chemotherapy, there can be low blood counts during extended field of radiation. See the percentages of site-wise or each and every lymph nodal involvement that you see in cervical malignancies, which are of course included in our radiation field. First of all, before going into the treatment volume, the picture till the presentation, the first thing is the patients are treated in the supine position, and you use what is called a thermoplastic immobilization device that you see on the abdomen to reproduce the same position each and every day. And the treatment time duration would be around 10 minutes a day. It's an OPD based treatment. And for conventional treatment, you go for Monday to Friday treatment. It is 5 days a week. Usually you go for 25 fractions, and that would be around 5 weeks of total treatment for an external beam therapy. I mentioned earlier that we have two sets of machines, modes of treatment for delivering radiation. So the Cobalt 60 machines that we used to give earlier, it gives a treatment. It's a 2D kind of technique where you target the volume, where you see this is a treatment portal in which includes the L4, L5 level, which includes the pelvic lymph nodes. The lateral volume will be about around the pelvic brim, 2 centimeters beyond the pelvic brim. And the lower extent depends on the vaginal extent. For minimal or no vaginal involvement, it is just below the obturator foramen, or you include the entire vagina, as the case may be. This is for a pelvic radiation treatment. For a patient who's not so obese, you can actually go for a two-field treatment where you give this portal in the anterior and posterior direction, and that's how we deliver a treatment, which includes the uterus, the cervix, and all the target, the lymph nodes, the parametria, which I've discussed earlier. If you have an obese patient, you'll go for a four-field technique where you give 2 fields anterior, posterior, and there'll be 2 lateral portals. The lateral portals are these, where the posterior line would go through your S2, S3 junction. And this is keeping in mind the involvement of the parametria and the uterosacral ligaments. Of course, the superior and inferior borders will remain the same. The anterior border will be just beyond the pubic symphysis, and it takes into account the involvement, the position of your lymph nodes. So in a 2D technique, the portal, although it provides treatment to the target as such, you can have a lot of normal structures being irradiated unnecessarily. So with our latest machines, we have 3D conformal treatments. So this, in this 2D technique, the entire dose within the square field will be receiving this aforesaid radiation. Although the local control will be the same, you can have the side effects which are more with a 2D treatment. With our latest, with advanced techniques in radiotherapy coming in, with a 3D conformal radiotherapy or an intensity modulated radiotherapy where you can control the doses. We will shape the treatment portals. What you see in red is our target volume. So if you had been you're treating with a 2D technique, the entire organ in this area would be in this color because you're treating the entire zone without any conformality. But here you can shape it according to your target volume need with our current software and machines. So this is the axial section of a pelvis. This is a coronal and the sagittal. So this is how your pelvic EBRT portal would look like. So you can see the superior border. It comes from the common iliac. So it is usually L4, L5 level, or depending on the patient, you look at common iliac lymph node vessel bifurcation. How we do contour is that it's based on the principle that the lymph nodes are present in and around at 7 mm around blood vessels. So all the lymph nodes that you have seen earlier, it's surrounding blood vessels. So what we contour is blood vessels. We contour each and every blood vessel from the common iliac bifurcation, and then we give a margin of a 7 mm so that the entire lymph nodal region will be included in the contour. And this is what you see as the after contouring. This is a planning section where you have applied a beam, and this and the upper body, you can see it will be around L4 junction, L3, L4 junction. And the lower extent definitely depends on the vaginal involvement. So if there is no minimal, it will go only up to a 2 centimeter below the vaginal involvement. And how will we appreciate a vaginal involvement is, of course, by the clinical examination and during a planning scan, which is very essential for us before contouring. We keep a vaginal marker to know, so that in the CT you can appreciate it, and then from there we give a 2 to 3 centimeter margin to avoid treatment of uninvolved tissue. This would be the external field of breather. So you can appreciate the difference between the volume of disease that we treat in a regular pelvic external beam therapy and an external field radiotherapy. Because in external field radiotherapy, you can see here that you go up to D12. Or if you have in nodes above, you even go up to the grossly involved lymph nodes. So this is the conformal shape that you treat, wherein you can appreciate the bladder anteriorly, which is paired to an extent. It will be well within the radiation toleration limits. And this is the axial section where you contour the nodal region around the aorta, which is a para-aortic strip. So the volumes are the differences. I wanted to depict the volumes that we treat with a regular pelvic radiotherapy and an extended field treatment. So just a word about a pre-treatment. The planning scan that you do is in this position, which is with immobilization, and the procedure that we follow is we always go for a bladder protocol, wherein you treat with a full bladder and an empty rectum, so that the bladder pushes off the small bowel coming into the pelvis. And so small bowel is a sensitive organ where the patients can have nausea, vomiting during treatment. So there are two aims of giving a bladder protocol. One is to prevent the small bowel coming into picture, and second, you can reduce bladder toxicity as well. And you take a plain a CT scan in this treatment position, and which is transferred to our radiotherapy planning machines, and you have a contour with the specific targets, and you have a dose planning. The dose that you give is 45 to 50 gray with an external beam therapy. It's around 25 weeks. It's 1.8 to 2 gray per fraction. So the 5 fractions a week, and so which will go on for 5 weeks. It's around 10 to 15 minutes a day, and a full bladder protocol is employed. Coming to brachytherapy, it's the brachytherapy, the word depicts a radioactive source being placed near to or close to the tumor, where so why do you need a brachytherapy treatment? Why do you need a brachytherapy treatment in carcinoma cervix is that squamous cell carcinomas to give a good tumoricidal dose, you need to give at least 75 to 85 gray to your target gross disease for good tumor control. But there is a limit to what we can give through an external beam radiotherapy because of the dose, radiation tolerance dose of bladder as well as rectum. So that is why you give target volume, which includes the pelvic lymph nodes and your target to a dose of 50 gray. And following that, you'll go in for a brachytherapy to deliver the rest of the dose. When do you start a brachytherapy dose? Brachytherapy treatment is according to your tumor regression. In the early stages, even you can intercalate between the external beam treatments from your 4th or 5th week of treatment, or you start after your entire EBRT course within a span of a few days to 1 week maximum. The idea is the entire treatment of external beam and brachytherapy should be completed within a span of 8 weeks. Why? Because we have trials to prove that 1 day delay in treatment, overall treatment time can reduce the survival and the local control. That is why you stick to that overall treatment time protocol. Coming to the instruments, this is a Fletcher suit applicator that we have. The central needle, the applicator that you have is that goes into the uterus. The other two are the colpostats, which will be placed in the vagina. So how do you, and these are other instruments, you have a whole lot of different variety of instruments these days. And this, the picture A that you see are the interstitial brachytherapy instrument, wherein you can put in as many needles as you want according to the disease involvement to achieve a good tumoricidal dose. So in earlier times, with brachytherapy, what we could achieve was the gross disease in the cervix or the adjacent medial parametrium and the upper vagina, where was the target for the brachytherapy, and that is what we could achieve. But with these instruments, with interstitial brachytherapy needles, even a lateral parametrium or a gross disease in the vagina can be given a good dose after external beam therapy. And brachytherapy doesn't take into consideration, it does not treat the lymph nodes because of the rapid dose fall off from the source. These instruments, what you see, these needles and the catheters, the applicators, what you see are the channels for the radioactive source to go into the tumor or close to the tumor. So what is a radiotherapy source is usually what we employ is iridium-192 or a cobalt-60 source. This is a brachytherapy machine that you see, and if you can appreciate all these channels where you put in these tubes or channels through which the radiotherapy source goes. So this instrument will have a single source of radioactivity, which is iridium-192, which is the size of a ballpoint pen nib, which is 0.9 into 4.4 mm in size. It's a single source. And when you, the application, after the applicators are placed inside the patient, you connect the device to these applicators, and through this and with a computer controlled system, this source goes into through these channels and delivers the dose through each channel from the as you have placed the catheters or the needles. Again, the duration of treatment, it depends on the activity of the source, which comes down as time goes by. So it could be from 10 to 15 minutes usually. And we give usually what we give is weekly once treatment, and it can be for a period of 2 weeks or 3 weeks according to the dose. There are different dosage schedules. The whole
Sorry to
idea.
interrupt, ma'am. We are running out of time. Can you please conclude, ma'am?
Okay, fine. This is the one. This is a pear-shaped dose distribution that you see with brachytherapy. That is, so you can see the laterally you have a good dose fall-off where the normal tissues will be spared. Just a word. Just can I just take 2 minutes for 2 slides to just conclude on? It will be 7. The dose on brachytherapy, which can be usually 3 weeks of treatment. 3 weeks, it is once weekly for 3 fractions. And just to conclude, for if you have a pain or bleeding in stage 4 disease, radiotherapy is a good effective method to control the local disease. It could be an 800 single dose or a 20 grain 5 fractions or a 30 grain 10 fractions. And it depends on the performance status of the patient as well. So what you have is for with radiation therapy, adverse effects are usually nausea, vomiting. You can have dysuria, and the most common symptom that patients can complain of is loose stools because of the bowel involvement, which is controlled with conservative measures. You can have low blood counts during treatment because of chemotherapy as well. The skin reactions are seen only in case of lower vagina is being treated, especially with our advanced techniques. The late reactions you can expect after 1.5 to 2 years is radiation proctitis or cystitis usually. You can have telangiectasia and bleeding, and vaginal adhesions or vaginal stenosis even. Thank you.
Thank you, ma'am. Anit sir. Anot.
Yeah. Thank you, Dr. Aisha, for giving us a inside view of what is happening during radiotherapy and the various methods and where all it is indicated. I would want to ask a few questions. With the advent of IMRT over the last couple of decades, what is the change in relation to adverse reactions as compared to the conventional cobalt-60 therapy we have seen over these years? Is it quite different than what it was before?
So if you could remember the slide where, like, in cobalt therapy, there is no way we can control the normal tissues being treated in our area. The entire portal will get the same dosage. So with IMRT and 3D conformal, you can shape a disease in such a way that you can have a definite, each and every organ has a definite radiation tolerance dose. So you can significantly control the symptoms that you see, the toxicity profile, the acute toxicity profile is. So what we see with our patients is frequency of loose stools is what we see very commonly. The skin reactions have definitely very much come down with the advent of 3D CRT and IMRT. And if you're following a good bladder protocol and
Can't hear you, Dr. Aisha. Can't hear you, Dr. Aisha.
Dr. Aisha, you're not audible.
Dr. Aisha, you're not audible.
For the time being, Dr. Mumtaz, shall we move on to the next session?
Yeah. Okay. Thank you, Dr.
Some
Aisha,
technical issues are there.
I think we can, yes.
Okay. So the next session is on national policy on CA service and current scenario. Speaker, Dr. Preetha George. Chairperson, Dr. Georgie from Kochi, Dr. Mini from Kochi.
Preetha ma'am, if you could
Over to
please.
you, madam.
Dr. Preetha, will you please? Dr. Preetha?
I'm really sorry for some technical mistake. Hello? Hello?
Okay, madam, you're not audible.
I'm really sorry for the technical glitch. Is there any question which I can answer?
I don't know. Are we going back to the old session? Dr. Preeta is not yet ready.
Yes, Anuj, please carry on to the older session.
Okay, so we were asking about IMRT. One more question which we wanted to ask is, with the advent of chemoradiation for advanced cancer cervix, how does it correlate with the use of chemoradiation and radiation alone? How does it correlate with the disease-free survival rate and the disease progression? Do you know the data which is available?
The local control rates with radiation definitely depends on the stage of the disease. So you have in stage 1, it is above 90%, 90 to 95%. When you have stage 2, it is around 70 to 80. When you have stage 3 with involvement of para-aortic lymph node and all, you have local control rates which goes down to around 40 or 50%. This is the local control rate. Chemotherapy acts which is potentiates the role of radiation, one. And the radiotherapy alone is given only in 2 scenarios. One is in stage 1 disease wherein you cannot operate and you go for radical radiation, or you have an elderly patient wherein you have limitations to give chemotherapy. But there you see a low chance of local control being possible with radiotherapy alone. And again, in NCCN also recommends for poor responders surgery post chemoradiation if your disease control is not is not complete.
Thank you, Dr. I think there are no questions in the chat box. Thank you for your wonderful presentation. Go back to Dr. Adarsh.
Yeah, okay, Doctor. I think Dr. Preeta is ready for the presentation. Over to you, madam.
Hello. Thank you, Kfog, for giving me the chance to present today. And my topic today is. Unmute. Can you hear me?
Yeah, you're audible.
Yeah. My topic today is cervical cancer, national policies, and a current scenario. As we all know, cervical cancer death occur in India. 5% of women in the general population are estimated to harbor cervical HPV 16 or 18 infection, and 83.2% of the invasive cancers are attributed to HPV 16 or 18. Eliminating any cancer would have once seemed an impossible dream, but we now have the cost-effective, evidence-based tools to make that dream a reality. The Globacon, that is the Global Cancer Observatory Division of WHO, 2020 has told that 123,907 women are diagnosed with cervical cancer every year, and 77,343 women die of cervical cancer every year in India. And the most significant of all this thing is that only 1.9% of women between 15 and 49 years is undergoing cervical cancer screening every year, which is quite shocking with all our memories. What are the cancer initiatives we had over these times? The National Cancer Control Program in 1976, National Cancer Registry in 1981, District Cancer Control Program in 1990, and National Cancer Control Program as integrated with NCD program, Non-Communicable Disease Program. Then the National Cancer Grid in 2012, and there's a revision of the NPCDS scheme. National Cervical Cancer Screening Program in 2016, and 2023, the first phase of the Indian vaccine rollout has commenced. National Cancer Control Program, which was launched in 1976, the priority was given for equipping the premier cancer hospital or institutions. Later on, the strategy was also revised and stress was laid on primary prevention and early detection of cancer cases. And this laid the foundation for the District Cancer Control Program. Then coming the NPCDS, that is National Cancer Control Program, which was integrated with the national program and for prevention and control of diabetes, cardiovascular diseases, and stroke. And this comes under the National Health Mission. The screening was provided by the auxiliary nurse and midwives. District hospitals were linked to the nearby tertiary care centers, and public and private partnerships promoted. Research and surveillance was also advised. The primary level, there was education done by the ASHA workers, monthly visit by the MO to monitor the progress, and periodic training of the health workers. Also, there is mass recruiting campaign and screening. And there was utilization of the lab technology. The secondary level, there is always a gynecologist who is trained for the colposcopic procedures. At least there is one colposcopy in 1 to 3 districts, and also there was facilities for thermal and cryoablation unit. Tertiary level, there was improved training in RCC and training centers. Then the National Cancer Registry was established to register each case which was considered a CERVICAL, and this was a long-term effort of the ICMR. This will give us a correct incidence of the cases, the causes, and there were population-based registries around 21, which is recently increased, and hospital-based registries were also there, so that we can get a correct account of the number of cases that we have. And the National Cervical Cancer Screening, introduced by the Ministry of Health and Family Welfare, it recommended cervical screening using VIA every 5 years in low resource setting. The cancer screening efforts included KAP surveys, knowledge, attitude, and prevention method surveys, screening with cytology, VIA, and HPV. And there was advised screening camps which were not very effective due to apprehension. In January 2023, India has started the first phase of vaccination campaign. And there are 68 million girls, 9 to 14 years, which are expected to be vaccinated by 2025. And only less than 1% of the girls are vaccinated till now. The states have taken up the role. Delhi is the first, started as a first small center to start vaccinating. And Punjab later started more statewide vaccination. Sikkim was the first state to completely vaccinate girls between 9 to 14 years. And this was completed in 2018, way long before. So each state can take an initiative in vaccinating their girls. Also, there are national adolescent programs like Kishori Shakti Yojana, Sabla Scheme, all to empower girls and empower India. There are contributions of professional organizations like Kfog, AOGIN, ISCCP, AGOI, Kfog, and our local groups. By keeping correct screening guidelines, awareness talks, screening outreach camps and all, we can reach more and more of the population. Yet with all these things, we understood that India has a long way to go. Screening for cancer cervix is only 1.9% as per the latest surveys, and vaccination is also less than 1%. The strategies which are advised are cervical cancer should be made a notifiable disease. There should be a national policy for prevention and control of cancer, and there should be increasing awareness by healthcare workers. And no vaccination will become a success unless it becomes a portion of the national immunization program. So, including HPV vaccination in the national immunization program should be implemented. And also you can add digital technology to cancer screening and to data collection. January 2024 was considered as a National Cancer Awareness Month to learn, to screen, and to prevent cancers. Thank you.
Thank you, Madam, for such an informative presentation. Over to chairpersons, Dr. Georgie.
Thank you, Dr. Preeta. I think she has mentioned all the points crystal clear, how this screening and prevention of cancer of cervix goes to the national level by different programs and what the programs different states have initiated. Probably in future, maybe we should go ahead with vaccinating boys also, because that would also reduce the community load of HPV infection also. Looking for any questions in the chat box. I hope that there are no questions.
Yeah. Thank you, Preeta, for taking us through the current Indian scenario and the government initiatives to for the screening and the vaccination protocols on district and national level. Though the National Cervical Screening Program started in 2016, it is really disheartening to find that only 1.9% of the screening procedure is there when you take all over India. But it may be different in each state. And this 38 million girls are waiting to be vaccinated by 2025, and only less than 1% is already vaccinated. So maybe as gynecologists, we have a social commitment. Maybe those people who come to the OP, we should do the screening, and maybe we should ask their children or grandchildren to have their vaccination. And those working in medical college, maybe we can give talk to our own medical students and have a talk with their parents and give them this vaccination. Thank you.
So I think we have come to the end of this webinar. I express my sincere thanks to all speakers and all chairpersons, and also to Dr. Adarsh for being the expert for this webinar. If there are any doubts, to the last speaker, Dr. Preeta. I don't see any doubts. So shall we wind up this?
Sure.
Thanking all once again. Good night.
Thank you.